Good morning, everybody. Welcome to Medical Grand Rounds. As you all know, we have been trying to sort of have certain, I guess, recurring topics within Grand Rounds. So in addition to, you know, our usual sort of highlighting the work that's being done in the department and so on, there is this series that we started, I guess it was about 1.5 years, maybe 2 years ago, around bringing awareness to the impact of the social determinants of health on health outcomes. And, you know, I not just recognizing that it's an issue, but also providing tools for individuals to do something about it. So that's sort of the spirit with which we wanted to have this round. So before I hand it over and introduce Dr. Lee, I would like to start by respectfully acknowledging that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. So very fortunate that Karen Lee and Dr. Karen Lee and Dr. Richard Lewanchuk have agreed to sort of take on this social determinants of health working group, where they've determined a few initiatives that we as a department will be moving forward with, predominantly around education, because at the end of the day, we have to feel that we're making an impact, and it's such a big issue that, you know, identifying ways that we can make an impact. So this sort of carries on in that light. Of course, Dr. Lee is a public health physician in our division of preventive medicine. And so I'm going to hand it over to you, Karen.
Thanks so much, Norman. Hopefully everyone can hear me. I want to thank Norman for her support of Richard and myself on the Determinants of Health Working Group. It's a cross-division working group that has had basically about 40 faculty and some residents too from, you know, across divisions in the Department of Medicine involved in this working group. And on behalf of the working group, we have been brainstorming and bringing topics to Department of Medicine Grand Rounds every few months. On the determinants of health to both increase awareness and education on it, but also, as Norman mentioned, to identify resources and tools that could support our physicians, faculty, residents, and other healthcare staff in better addressing these determinants of health in their day-to-day practice at their hospitals and clinics. So welcome everyone. Thank you again for joining us in this Determinants of Health series. Today's topic is a very apropos. It is Social Work Week and National Nutrition Month right now. And so we're very, very pleased that you know, we have this panel of folks who could join us. So the topic for today, everyone, is household food insecurity and guidelines that you can use for supporting your clients and patients. We have 2 speakers followed by a panel. Our 2 speakers today are Heidi Olsted. Heidi graduated from the University of Alberta with a Bachelor of Science in Nutrition and completed the integrated internship program to become a registered dietitian. She then completed a Master's of Science in Health Promotion, also at the U of A. Heidi started her career as a public health dietitian with a focus on maternal and infant health. Heidi then worked in Central Zone as the Nutrition Services Manager with portfolios that included public health nutrition and ambulatory care. Heidi is the current Program Director of Evaluation and Population and Public Health for AHS's Provincial Nutrition Services Strategy. So thank you, Heidi, for joining us today and also helping to organize the distinguished panel that we have here. After Heidi, Michelle Letourneau will also be speaking. Michelle is a public health dietitian as well with Alberta Health Services. She graduated also from the University of Alberta with a Bachelor of Science in Nutrition, completed the integrated internship program, and became a registered dietitian. As a public health dietitian, Michelle is a nutrition consultant for other healthcare professionals and educators. She also supports healthy eating in community settings through work with sectors including schools, early learning and childcare centers, and public spaces. Michelle was drawn to dietetics because she loves all things food, and in her belief that health is something that's important for all. And then followed by Heidi and Michelle's presentations. We will also have basically a panel of folks from social work. So we have 4 panelists, including Bonnie Vander Putten, who is a social worker with QEP, the new Grand Prairie Hospital. Welcome, Bonnie. We will also have Christina Davis, who is the social work clinical lead in Edmonton. We will then have, we will also have Shelley Perkins, who is a registered social worker and a continuing care counselor at the Red Deer Regional Hospital. And we also have Deb Samek, who is a practice director with Provincial Social Work. So, you know, we've got a whole host of folks from multiple areas in Alberta, and we're very excited to hear what you have to share with us today. Everyone, I mean, as you guys know, access to affordable, healthy food is a cornerstone of people being able to both prevent disease and manage diseases, particularly chronic diseases, once they become ill. And that issue of affordability of healthy foods can come from multiple angles and determinants. One angle, of course, is there physical access to that food within your community and nearby to where you live or work, or where you're in living your day-to-day life. Another, of course, is do you earn a sufficient income to allow you to access affordably those foods that might be in your neighborhood. And this is an issue in terms of food security or food insecurity that has been growing over time. So, when we first started in Canada, a minimum wage in the early 1970s, basically, if you were an adult working about 40 hours a week, you could support yourself and one other person at that low income cutoff level that's been defined by Statistics Canada. By the 1990s, inflation had grown, but not minimum wages, not indexed sufficiently to inflation. And so by the 1990s, not to say now, but by the 1990s, if you were working a minimum wage job, you would have to work something like over 70 hours a week in order to reach that low income cutoff that would support you and one other person in your household. One of the issues, of course, that you'll hear these guys addressing is that issue of incomes and income inequality. And income inequality, doesn't affect, I think, just the poor, even though it disproportionately affects those with low incomes. But there are some studies to suggest that income inequality impacts all of us, including those of higher income. So there are some studies, for example, comparing the UK and Sweden. So the UK has higher income inequality, Sweden, lower income inequality. And there are findings that some health outcomes are actually worse in the UK for the wealthy, for example, infant mortality, compared to a more equal society like Sweden. And so it's an issue that affects all of us and the spectrum of our patients, but of course, disproportionately those who have low incomes and then are impacted as well by issues like household food insecurity. Anyways, certain temporary measures have arisen, such as food banks, including in Edmonton. We had the first food bank in Canada in 1981, and it was supposed to be a temporary measure, but needs for that have grown. So anyways, without further ado, with these issues of household food insecurity that is impacting so many of our patients, and then impacting our ability to both prevent and manage disease, I'd like to turn it over to Heidi. So Heidi, please take it away. Thank you.
Thanks so much, Karen, for introducing the topic and setting the stage for us today. So yeah, we're excited to be here today to talk about household food insecurity, as it is an issue that impacts a significant number of people in Alberta, if not all of us in Alberta. And in recent times today, we're hearing more and more from healthcare providers that their patients are struggling to meet ends meet, and they just don't know exactly what to do when patients come to them and are struggling with this. So we've heard lots in the news recently about the prices of groceries that have been rising steadily, but there's a lot more to this story, and it's a story that has been a problem for a long time and continues to be getting worse. So where we're going to start is a little bit about household food insecurity prevalence in Alberta and who is most at risk. And then I'm going to chat a little bit about how it impacts health. At that point, I'll pass it over to Michelle, who will be talking about our recently released household food insecurity nutrition guideline and some of the key information in that resource, such as what evidence says about how to support clients experiencing household food insecurity. And we'll conclude showing you some resources that can support you in your practice. So very excited to be here today. We do have a quiz to start it off. And so if you have a secondary device, you can use the QR code, or if you're on a desktop computer, you can click the Slido link, go to slido.com and enter that number. And our question for you today is, on a scale of 1 to 5, how often do you ask your clients about their financial situation as part of your clinical assessment? Okay, so the numbers are still changing a little bit. We'll give people another minute or so to get those in. This is super interesting. I can see that right now we're sitting at, about 20% never asking that question, but kind of cool. I see about 36% are sort of, oh, we switched. We're moving up and down. Maybe I'll give it another minute before I say anything. All right, they seem to have stopped moving. So yeah, so 3 to 4 seems to be our commonest. So it sounds like quite often we might be asking this question, but for some never, and for some it's the practice of always. So as we go through, we'll be chatting a lot about financial strain and sort of how to ask questions and have those conversations and why it's important. So we can move on to the next slide. Thanks. So what exactly is household food insecurity? So household food insecurity is when financial strain causes inadequate or insecure access to food. So it's essentially when the money that people are making, all of their income sources are not enough to cover their basic needs. And because we have certain basic needs, that are fixed, like rent, utilities, childcare, it's often food and medication that are the first things to go. And that's when we start to experience household food insecurity. So how frequent is this in Alberta? And so in 2021, PROOF, which is an interdisciplinary research program out of the U of T that studies effective policy approaches to household food insecurity, used Statistics Canada income data to show that 15.9% of households in Canada experienced household food insecurity. However, our numbers in Alberta are actually the highest in the country, sitting at 20.3%. And so as we talk a little bit later today, we're going to be breaking household food insecurity down into the 3 categories that we have. And so we have marginal, and marginal is that worry, the worry of running out of food, and also the limited selection due to lack of money. Then we move down to moderate, where we start to compromise our quality or quantity of food due to lack of money. And then when we get to severe, that's when we're missing meals, we have reduced food intake, may go days without food. But at all levels, we see that people experience psychological distress about running out of food before there's money to buy more. And household food insecurity isn't just about hunger, it's really about the stress and the limited variety of foods that the household has, and that can impact health at all levels. So who's at risk of household food insecurity? And so there's a broad group of individuals who are at risk. So low income, of course, is the biggest predictor of household food insecurity. And Dr. Karen Lee set the stage fairly well when she talked about, low income. And I think we often think that households where there's unemployment might be the biggest risk, where we're relying on social assistance. And those individuals do have the highest rate of household food insecurity at about 63%. However, even when people are employed, that's actually our primary driver of household food insecurity. 61% of the households in Alberta that are experiencing household food insecurity actually are households that rely on wages and salary as their primary source of income. So employment is not always enough to prevent household food insecurity. And there's, several factors for that: low hourly wages, seasonal work. And then, as you can see, we have a number of other groups listed here on the slide, and it's really individual groups that face social and systemic barriers that put them at greater risk for poverty. So people who rent rather than own their own home are at higher risk. Female single parents are at higher risk. Households whose members identify as Black or Indigenous, both on and off reserve, are at higher risk. Households with children under the age of 18 are higher risk. Post-secondary children, students, and those living with disabilities. We do have to remember that, not all of these individuals, however, do experience household food insecurity. So, specifically, we see some extremely high rates in Indigenous peoples. We see the household food insecurity rate being 2 to 3 times the general population, and 57% of on-reserve First Nations households in Alberta have experienced food insecurity in the previous year. So I think, a lot of times we see information, and when we're out in the community, people talk about different ways to help people with household food insecurity. And there's a perception that, helping people learn how to budget or shop, or providing services like gardens and kitchens and food banks might help things. But really what we know is that the research has shown that there's really no difference in food skills between those who experience household food insecurity and don't. And chances are people who are experiencing household food insecurity really know a lot about how to manage money and a budget, probably more than many of us. And really, it's the lack of income and the lack of money that is their biggest barrier to accessing healthy food. So how does this impact health? So all levels, if you can go to the next slide, Michelle. So all levels of household food insecurity are associated with adverse health outcomes, including poor diet, increased diet-related diseases, and mental health conditions. There's strong associations between individuals experiencing household food insecurity developing certain chronic conditions. They're more vulnerable to infectious disease, poor oral health, injury, chronic conditions, depression, anxiety, heart disease, hypertension, arthritis, and they're also at risk of being diagnosed with multiple chronic conditions. So, and then when we get then we think about managing those chronic conditions, we also see that adults living in food insecure households are more likely today to delay, reduce, or skip prescription medications due to the cost. So it makes household food insecurity makes it difficult for individuals to manage their existing chronic conditions and can lead to worsening of conditions. Food insecure individuals may struggle with adherence to therapeutic diets and forego necessary medications because of the expenses. So as you can see on the slide, as you become more food insecure, the likelihood that you're not going to take your medication goes up significantly. And I thought it was super interesting in this study that, it doesn't matter if you have an insurance or not to cover that. If you're household food insecure, whether you have insurance that, is copay for your medical expenses, you're just as likely to skip your medication because you can't even cover the copay costs. Next slide. Okay. So adults living in more food insecure households are also at greater risk of poor mental health than those living in food secure households. And this is interesting because compared to covariates like income source, immigration, education, and race, household food insecurity has the largest individual impact reporting adverse mental health outcomes. So you can see there's, 6 different adverse mental health outcomes shown on this slide, and they all show a gradient with household food insecurity. And as we sort of increase, there's a twofold difference in the burden of mental health outcomes between food secure and marginally food insecure households. And it is considered an independent risk factor for adverse mental health outcomes. It's hypothesized that household food insecurity impacts mental health due to the unique stresses associated with the biological and social implications of not having enough money for food. So food insecure adults are also more likely to admitted to acute care and more likely to be sick. So linking survey data on food insecurity to hospital records demonstrates that more severely food insecure adults have greater odds of acute care admission, same-day surgery, and being a higher cost healthcare user. More severely food insecure adults also stay in acute care for longer and are more likely to be admitted. Next slide. Yeah. So just to sort of take this full circle, we've talked about how household food insecurity increases risk of poor health, and clients who have chronic conditions may in turn increase their risk of household food insecurity. Of course, this is because of increased costs to access healthcare, transportation, parking, childcare, expenses related to managing their conditions, equipment, supplies, medications, decreased earnings due to their inability to work. So all of these things sort of are a cyclical nature to increasing the risk that the patients that you're seeing every day are more likely to be experiencing household food insecurity. So over to Michelle.
All right, let's talk about how we can support clients. So during this section, I'm going to share some recommendations from our new household food insecurity nutrition guidelines. And truly, we all have a role to play in understanding the role of financial strain and the impact that it has on our clients and their care plan. I'll share a video that illustrates how we can all help.
I remember entering the consult room one morning and greeting Mark, who wore a big oversized toque and a giant smile. As usual, he seemed engaged and eager to manage his diabetes better. But after a whole year of working with him, nothing had changed. His blood sugars were still wildly out of control, and his eating habits were poor. I really wanted our discussion that day to be different. I didn't want him to live the rest of his life with the potentially terrible side effects of unmanaged diabetes. As we started reviewing his home readings and recent lab work together, I knew that things were still the same, if not worse. Have you been taking your insulin? Or have you forgotten any doses? Nope. I have been using the long-acting and taking my short-acting with meals. Okay. What have your meals been looking like? Well, I usually skip breakfast, but I always have a good supper. Do you snack throughout the day at all? And what do your suppers typically look like? No, I don't really snack at all, and I usually have a big bowl of soup or noodles for dinner. Can you tell me a little bit more as to why you typically eat this way? Well, it's half habit, half necessity. Suddenly, it was like the lights turned on in the clinic room as Dr. Joseph and I both stopped and looked at each other. We had been working on a project for the past few months about reducing the impact of financial strain on people's health, and that phrase, half necessity, took on a whole new meaning. We paused for a long time as our treatment plan whirred through our minds. We had planned to refer Mark to a retinal consultant, a healthy living class, a dietitian, and we're already thinking about different interventions we could use to mitigate his progressing diabetic complications. But instead, I turned back to Mark and asked, "What do you mean out of necessity?" He squirmed a bit, coughed, and with an awkward smile said, "Well, I don't have that bursary for school anymore, and I haven't been able to find a job yet. And my mom lost her job recently, so we just don't have a lot of money for food right now." Over the next month of weekly meetings with Mark, our team helped him apply for Alberta Works, provided him letters of support for various government programs, brought in his sisters to expand his support network, and arranged for his medication coverage.
So in this video, if you watch it later, we will see that in the video, there's someone named Mark, and his healthcare team is able to come to the understanding of how his financial situation impacts his chronic disease management. And this is from the Reducing the Impact of Financial Strain project in Alberta. And they found that some of the results were that 93% of patients agree that being asked about their financial situation relates to better health. So not only is it helping patients, making the care plans more realistic, patients are actually comfortable with it and agreeing that yes, this does relate to better health, and I'm okay with being asked about financial strain in a clinical setting. So our nutrition guideline has 3 sections to it. It's recommending that, first off, we are asking people about their financial strain. So we can't do anything about it if we don't know about it. So asking is very important. If somebody is experiencing financial strain, then we want to move on to assessing risk in terms of what impact is this financial strain having on a person's access to food, on their access to medications, things like that. And then we want to develop the care plan with these things in mind to make sure that it's actually implementable for the client and not adding to the burden of finances. The next step would be, if the client is interested, we can intervene by connecting them to financial supports, whether this is through a social worker or maybe in your role, you do have some capacity to connect yourself. So we'll talk about in the guideline, what are some of those actions that you can take. So here's the first step, just identifying whether a client is experiencing financial strain. And this is going to help you develop a better care plan. I know that it might seem awkward to have conversations about finances, and a lot of us healthcare professionals feel that we might have a lack of knowledge and experience on this topic. And I'm here to tell you today that you don't need to have all the answers. And in fact, this is not about solving the patient's financial strain. This is about understanding how a client's financial situation can affect their care plan. And when you understand this, healthcare providers, they can respond to a client's needs, link clients with what they need. And in turn, if this reduces the client's stress concerning their finances, this in turn can improve management of their health. So you look down at the bottom, and we have a source. It's identifying financial strain and addressing financial barriers to healthcare. This is a course made up of multiple modules. Our AHS Social Work team was involved in building this. They took the lead on it. And this course will tell you exactly how to ask about financial strain. It has a lot of tips about making it a nice, safe place, about how to have this conversation respectfully and keep rapport with your client. because we know that is the most important. Some of the barriers that we know healthcare providers have to asking people about financial strain is, of course, the sensitivity around the question, right? We're very concerned with keeping rapport as well. We all face extreme time constraints, so that's another barrier. And lastly, you can't ask something like this if you don't know what to do afterwards, right? If you're collecting the information, you need to do something. And so this guideline intends to empower you with that info. When you're going to ask about financial strain, you need to first ask for permission and normalize it. So what I have up on the screen is in no way a script. It's just an example of how you can do this. This will vary from client to client and depend on your relationship with them. And this conversation could happen at different times, right? You might meet this client many times before you have this conversation. We've also heard of clinics who have had success with building this sort of conversation into even a waiting room survey. So it can look very different depending on where you are and what your role is. But asking for permission and normalizing could involve explaining what you're going to do with the information. So how much money someone has to buy food affects their nutrition. And I ask all of my clients about this so that it can help us develop the care plan. So that explains why you're doing it, what you're going to do with this info. And then clients need to know that providing this info is optional, right? When you're unsure in a healthcare environment, just knowing things are optional is very important. So just ask if it's okay that you ask about the financial situation. And again, if you want to visit those modules before you embark on anything like that, I think that's a great idea because they provide a lot of helpful tips about how to do this and some more sample scripting of how this could look in real life. Up on the screen here is a validated question used to detect financial strain. It was developed by the Center for Effective Practice with support from the Alberta College of Family Physicians. And this question also appears on the Connect Care Social Determinants of Health module. So if you go in there on Connect Care, you'll see this question prompting you. And this is a place where you can chart on these conversations. If you have access to Connect Care, you can chart here, and you can also see if someone else has previously had this conversation with the client. So the magic, even though this question is validated, the magic isn't really in the exact question itself, right? The magic is in the fact that we're addressing the social determinants of health in healthcare. And not all clients are going to understand making ends meet, right? That's the reality of it. So you might ask this in a different way. Sometimes it can come up organically through conversations about basic needs. But Module 2 does suggest some different ways that you can ask this question. The second step is all about understanding the impact of the client's access to, understanding the impact of financial strain on the client's access to food and developing a care plan based on their situation and their priorities. As you move into this step, this is where you're going to start asking clients if they're experiencing financial strain about what basic needs they're struggling with. So you might find out that they're experiencing inadequate income for food, medications might be their top priority, or maybe they're just worried about housing right now. And if you're building a nutrition-related care plan, you're going to get more specific food and nutrition-related answers as part of your clinical assessment to help you understand their situation around food. So you might be asking things like, how many times does your client eat in a day? What foods do they usually have? Also, where they get their food. And you can imagine this would be important for any medications that relate to food, right? So you can start to imagine how this conversation builds and how it really does fit in with healthcare. And through this discussion, you might end up identifying other barriers to accessing food outside of finances. You might find that your client is in a very geographically isolated place, or maybe they have physical limitations like mobility issues that are impacting how they're able to access food. So sometimes even with these other barriers, you're able to assist a little bit with that. For example, I know a lot of registered dietitians, if they're in urban areas, they're able to stack on free or subsidized transport services or delivery services onto food bank services to help people actually get the food. So when you're having this conversation, other barriers might come up and you might be able to assist with that. Now, as a healthcare professional, this is really hard because we want to solve problems. But then in the case of household food insecurity, in almost every case, we're not going to be able to totally fix the problem, especially not as a frontline healthcare professional. But what we can do is we could reduce the impact of financial strain. And we can provide our clients with compassion and care, and we can adapt our approach based on our understanding of the barriers that somebody is facing. So don't put the pressure on yourself to solve the problem. This is about reducing the impact. Our nutrition guideline contains some examples of consideration for talking about food with clients. So we have some examples of conditions or situations that are impacted by household food insecurity and how this might change how you're talking about food with them. So these are just examples. It really depends on the client, but it's food for thought. And we have some examples for with diabetes, hypertension, and for parents of infants. So moving on to step 3, this is about intervening and connecting if your client is interested in receiving these sorts of services. Some of you might have access to a social worker, and if you have more questions about this, it's great because we have them on the line as a panel, which is fabulous. So you can consider a referral to a social worker to help clients with benefits and support navigation. So I have some suggested reasons for referral up on the screen. And if you're able to continue the conversation and your client is receptive, I suggest talking about taxes. And you can say something like, occasionally you come across people who are really tight on money, and sometimes there are benefits waiting for them if they did not file their taxes last year. And if you don't mind me asking, did you file your taxes? If not, maybe we can find a way to look into this. And this is important because tax returns are required to access so many income security benefits like GST credits, child benefits, working income tax benefits, property tax credits. And another example would be the Alberta Affordability $100 payments to seniors and families with children. If you don't file your taxes, you don't get access to these easily. And that could look like $1,200 for a family with 2 children. So it definitely can be significant. So if you're able to, it can be worth it asking this question. And a 2020 study found that 10 to 12% of Canadians did not file their tax returns. And it's estimated that the benefits lost to working age non-filers was $1.7 billion in 2015. Does this surprise you? Maybe, maybe not. But non-filers were most heavily concentrated in the lower income brackets. And barriers can include language, cognitive issues, just general overwhelm, or lack of awareness. So claiming taxes is definitely important for accessing the benefits that your clients are entitled to. On a client level, one project found that individuals who are experiencing household food insecurity were able to access $2,600 per person in refunds and benefits after filing their taxes with the support of a community organization. In this case, it doesn't apply to everybody, but the impact can be huge for some individuals. Some of our resources for benefit navigation include Alberta 211. I found a lot of success using the phone and chat options just to give me an idea of what might be out there for a client. As well, a great resource is the Family and Community Support Services, FCSS, in different communities throughout the province. These folks are on the ground, they're in the know. They're going to often know about smaller community programs that might provide a bit of wraparound support for your client that 211 might not know about. So they're definitely worth connecting with. We also have a brand new resource from AHS Nutrition Services that provides health professionals with a summary of funding options available here in Alberta for special diets and nutrition products. It lists required steps for these funding requests, and it even has letter templates for you to submit to programs. So we have the QR code on the screen. If you go back to a recording of this on the DOM page, then you are able to grab the QR code with your phone and navigate right to this. I'll also show you the website where it lives. Now, about 60% of people who are experiencing household food insecurity in Alberta are actually receiving income assistance. So for those who are on income support or AHS already, if they are eligible for special diet funding for certain conditions they have, it's worth looking into and connecting them with it. This doesn't look like a lot of money, but if you are experiencing household food insecurity, this can make a difference. So again, in that new resource we have letter templates so you can help your clients access this because it does require letters from healthcare professionals. Finally, some clients benefit from food banks and food pantries in conjunction with financial supports. So while food banks and cupboards really help in emergency situations, statistics show that only 1 in 5 people who are experiencing food insecurity are going to use the food banks. And instead, people are much more likely just to delay their bill payments or ask for financial help for their friends and families. So why are they not accessing these programs? Well, if you look at this slide, the criteria is pretty stringent. Sometimes it's quite overwhelming. Some people feel a bit of stigma from it, although that's not the intention. As well, when there's restrictions on eligibility, that means you can't access it all the time, so it might not be available exactly when you need it. As well, just because you're experiencing household food insecurity doesn't mean you absolutely have no food. And sometimes what happens is with these programs, you keep getting the same type of food, but the kind of food you need, like maybe milk or vegetables and don't have, isn't available. Of course, there's some difficulty with transportation, hours of operation. Maybe they don't provide foods that fit your culture or your medication needs. So that's, it can definitely be difficult, but the most important part is just knowing the realities and then helping your client out with the referral process if this is something that they want to access. Finally, we can't overstate the stress and pressure that the experience of household food insecurity and financial strain causes. So you might want to explore with your clients about whether access to social and mental health supports would be helpful. So in summary, we know that financial strain causes household food insecurity, and understanding a client's financial situation makes us more effective as healthcare providers, right? It takes time, but it makes us more effective. And as healthcare providers, we can all participate in ensuring clients get access to their income support and benefits. This might look different depending on your situation. Maybe you're just referring to social work because you have a close connection with them. Maybe you're doing some of the groundwork yourself. It can definitely look different, but we all do play a role. So I have a couple more poll questions for you if you want to pull out your phone again. So you can grab QR code with your phone camera on the screen, or if you go to your browser and type in slido.com and then the code number, you can participate in the poll. So we're wondering, based on this presentation today, on a scale of 1 to 5, how likely are you to ask your clients about their financial situation? So 1 would be unlikely and 5 would be very likely. So I'll just give you a bit to answer. We don't have the little tickers set up for this one, so that's why you don't see it, but it is collecting your answers. So thank you for participating. Okay, looks like I've got a great number of you. Thanks, everyone. Oh, I'll wait another second here. Okay. And our next question is, on a scale of 1 to 5, how interested are you in exploring the steps to addressing financial strain? So 1 being not interested and 5 being very interested. All right, thank you everyone for participating. So I'll show you a few resources to support those who are interested in further exploring this topic, and then let's get to our panel. We have our webpage, which is ahs.ca/food insecurity. This is where you'll find the new nutrition guideline, as well as that new point of care reference for funding supports. So definitely check these out. So you can go directly to the website, or you can use our QR codes to get there. We have the Identifying and Addressing Financial Strain course from AHS Social Work. If you have access to my learning link, you can find it on there. If you're Covenant Health staff, it's on Click. And if you have access to neither of those, don't fear, it is on YouTube. So we have the direct QR code into YouTube for it. As well, the Alberta Medical Association has developed a change package intended to help physicians and their team members implement practice changes that improve care for patients living with financial strain. So we have the link here, so check those out. There's a bunch of resources there. So let's open up our panel now. And if afterwards you still have questions, I do have a couple contacts here on the screen. If it's about the nutrition guideline, you want to know more about this process, contact us there. And if you're interested in other practice supports, we also have that email as well. So thanks, everyone.
We're going to open up to the panel. So I'm wondering if Shelley, Christina, I think, and Bonnie have comments. I don't see Bonnie on the screen, but I see Christina and Shelley. If you guys want to respond and add to, I think, or complement comments that Heidi and Michelle have made and have presented on. We'll open that up for now, and then we'll, ask for Q&A questions, which I'll read to you. Some of them have come in. But yeah, Shelley and Christina, please, we'd love to hear your thoughts and comments as social workers. Thank you.
Good morning, everyone. This is Shelley. What a wonderful presentation. Thank you so much, ladies. That was fabulous. I think, part of our role as social workers, we often address financial strain with individuals, and it's a big part of what we look at to help, whether that's for food insecurity or they can't afford medications. And I find for myself that I often, having that conversation with somebody, jumping right in and asking about their finances can be very difficult. So sometimes I find a softer approach works better. More sometimes asking about, do you have, if you're leaving, so I work at a hospital, if you're leaving the hospital, and you're going to need medications, do you have a way to cover that? And that lead in sometimes is a lot easier into talking about their finances and just jumping, hey, do you have problems with your money? Like, what's going on? So sometimes that softer approach can make a big difference with people too, and being willing to open up and talk about what's happening with them. Christina, I saw you kind of nodding. Do you have something to add?
Yeah, sure. Thanks for that, Shelley. And thanks, Michelle and Heidi. Like, that was such a great presentation. It's so wonderful, and we can work with our colleagues over the different disciplines to really support people in the social determinants of health. When we were creating those financial strain modules, we really tried to make module 2 accessible for folks who are outside of the social work world, because we didn't want folks to feel really overwhelmed with the idea of talking about finances with patients or clients. Because you can see how important it is. So we've talked a lot about the idea of listening to understand, and identifying our biases, and really approaching our patients and our clients in a really non-judgmental kind of, as we would say in social work, kind of anti-oppressive way. So not going in with assumptions, basically. And I think was it you, Heidi, who talked about the skills. So we can't assume that folks who are of low income or have food insecurity, we can't assume that it's because of their skills or their lack of skills, right? So I think that was a really important point that I want to highlight. We can't assume anything about our clients or our patients. We come in there and we ask questions, and we have to listen to the answer. We can't assume that because someone came from a specific community or a specific part of the city, or they come in looking in a certain way, we can't make assumptions about those folks, especially in terms of skills and abilities or motivation, right, to get themselves out of that financial strain situation. I think in social work, we talk a lot about what we call systems theory, but it's really person and environment, or the context. So what is bringing those patients and clients to us? What is, what's exacerbating the disease? What is bringing them back to hospital? You know, what's causing them to really struggle to manage whatever condition they're going through. And I think that's a lot of what social workers do, but I don't think other disciplines need to be scared of asking those questions. I talk to my social work students about how social workers bring the why. You know, why are people in this situation? How did they get here? And what can we do to support them? Really meeting them where they're at, not blaming, not judging, but just saying, hey, I see this, I hear this from you. Can I help you? Can I get someone else to help you? And it's just being human, right? Rehumanizing that person and just really listening, I guess, is probably what I would say.
Thank you, Shelley and Christina, for those additional thoughts. Very helpful. Heidi and Michelle, any comments that you want to make in response to whatever Shelley or Christina may have added?
Yeah, I agree. I love the concept of the softer approach and just building it into part of your conversation when it feels right. I think that's a great way to approach it when it's not where you start necessarily, but when you feel like it's the right time and the conversation is great. And yeah, a lot of what we do is sort of that myth busting, you know, sometimes that budgeting or the food bank are going to solve these situations. And that's just not what's going to solve the situations for individuals or help them manage their health better.
Yeah, that's really helpful. I think, Christina, what you're sharing. And that's the kind of thing that we all need to slowly learn about in our roles as healthcare professionals, because you don't start with this knowledge. School does not equip you with that type of knowledge. And so mentorship, help through modules, help through continued learning is just so critical. And it's good to hear from people who are doing it and finding success.
Thank you. Christina, did you have a response or an additional comment? Please go ahead.
Yeah, thanks, Karen. I was just going to say, maybe for some context, I don't know if everyone on the call has an idea of the benefit amounts that people would bring in per month, for example, if they're on Alberta Works or if they're on AHS. So just to share something like that, you might be working with folks who are really bringing in $800 or $900 a month total with income support. So when you think of $800 or $900 a month, you think about paying rent, you think about buying food, you think about paying bills, you think about transportation. In this city, in this province, we need to buy winter boots, we need a winter coat, you know, we need all kinds of things. These days, people actually need internet, and we talked about this in our financial strain modules about redefining what basic needs are and probably including access to internet as one of those basic needs, right? Especially during the pandemic, how that was so highlighted. And right now, the AHS benefits are more than that, and they've just gone up. But prior to the increase, people on AHS were bringing in $1,685 a month. So if you can imagine, one of the exercises in our financial strain modules is to say, you know, to whoever is taking the module, can you picture yourself in a situation where you have a sudden and drastic decrease to your income? What would that look like for you? Are you prepared for that? If your income is only, you know, between $30,000 and $50,000 a year, and suddenly you're not able to work anymore, you know, would you be able to manage that? What decisions would you have to make? What choices would you have to make? So we included that exercise as kind of a bit of an empathy exercise, but a bit of understanding. So happy to answer questions on context or what that looks like on the day-to-day for the folks that we serve as well.
Thank you. I think, you know, I think giving those amounts are really helpful in terms of giving people an idea of just exactly how much people have to live on. with some of these available income supports. Shelley, did you have something to add? And I do want to
Yes.
make sure we have time. There are at least 2 questions in the Q&A box that I want to pose to the panel. But Shelley, please go ahead.
I just wanted to add into what Christina was saying about seniors as well. Seniors, low-income seniors who are maximizing the 4 major programs, which is typically your CPP, your GIS, which is your Guaranteed Income Supplement, your OAS, your Old Age Security, and your Alberta Seniors Benefits. They often only are making between $1,700 to $1,800 a month as well. And that's maximizing all of their programs. So oftentimes that makes it very difficult for them as well.
Thank you. Yes, thank you for that ad, Shelley, really helpful. Okay, to the panel, there are 2 questions in the Q&A, and I'm just gonna reread them. So from Anna Oswald, I'm seeing more and more patients asking for AHS forms when their medical condition is not severe or is very likely to respond to therapy within the coming months. I feel a lot of pressure as they are facing severe financial strain, either with food or housing. What do you suggest for these patients for income supports without AHS? Feel free, guys, just jump in.
So we often find that people look at AHS because it's a higher per diem rate than what you would get on income support. And so a lot of individuals will look at AHS as a starting point, but income support is the starting point for individuals when they're looking at those types of things. And I always remind people that, you know, you can certainly apply, but AHS is a program that's a long-term program that's looking at your ability to be employed in the competitive marketplace and what you can or can't do to at least be partially employed. Have you gone through all your treatments and interventions? And I remind them of some of those criteria so that they understand that that's not necessarily the starting point, but if they don't have a financial income source, then income support is the place where they could start. And then we'll talk about how that looks, what they can do to apply for it, talk to them about the benefits of the program, like having health benefit coverage, as well as, you know, as noted in the presentation, you can get a special allowance for diets and those types of things as well. There are other program benefits too, things like medical transportation costs can be covered. So there are some real benefits to talking to them about what's within the program, and then that often will help them to go, oh, okay, let's use that as a starting point.
Thank you.
Yeah.
Any other comments from the panel?
I would say make sure that you have a social work consult in on those individuals. And I don't know if that question about the AHS medical is coming from the client themselves or the social worker. But make sure there's been someone involved to do a comprehensive financial and psychosocial assessment, right? So we can look at all the different areas where they might be able to find any other type of funding or support in the community, aside from just AHS. And the other thing to consider about AHS is people often turn to AHS when they feel they have no other options. So let's make sure that that person or that individual who is asking for the medical, let's make sure they really fully understand their treatment options and the potential treatment outcomes that could occur. Because I think that sometimes, you know, people are in a state of overwhelm when they're utilizing the healthcare system. And so sometimes maybe taking a step back and re-explaining some of the treatment options for them might also be of assistance.
Okay, thank you. I would like to get to our last question right before we wrap up, and we're nearing time. So the last question from one of our attendees is, one of the challenges I find is that these individuals are also in such stress, it can be hard for them to even think of doing more than one more thing. I find that the thing to be of most benefit is just a grocery gift card. Any thoughts on that? Love this presentation and its great ideas and supports. Yes, thank you so much to this panel for everything today. But any thoughts on things like grocery gift cards, and what are the possibilities of those being built in as like more regular supports? Thoughts?
I would absolutely love that. You know, why do we make people have to write a letter, go to the food bank, get their food that may or may not be nutritionally beneficial for them? Food banks were never created to be a long-term solution to hunger. Food banks were meant to be a stopgap solution, and our society has come to depend on them. So let me tell you, it's 10 times easier to give someone a grocery gift card, and they're just so thankful for it. And then they have the autonomy to make those choices themselves. So if there was a way to get more grocery gift cards, I'd be all over it.
Thanks, Christina. And I think it's one of those things around, it's a normal way to get food. There's no shame. There's no other things that are brought in when we use gift cards. So the nice thing about a gift card is, yes, it gets them access to food, which is amazing. And it doesn't increase their shame. It allows them to access the foods that are culturally acceptable and align with their food preferences and the needs that they have for their home. So yeah, there's certainly community programs that do offer gift cards. And when we as dietitians provide consultation around this, we often recommend that if you're going to provide this type of support, gift cards, food gift cards are a great idea.
Yes, and to add to this, we do see that in the research that clients are very receptive to the idea of gift cards, and they're very happy to be able to spend them on food and to be part of the regular food system, right? So it's a good experience for them. And it's positive, right? Instead of being kind of awkward and feeling like you're different and you're going through this whole separate food system. But as well, we're having some success with our CP&P programs in Edmonton Zone with providing gift cards. So that's a real life example of how it can work.
Thank you. I just want to thank the panel for all of your great presentations and comments. You could see in the chat box that there's many people writing about what an excellent presentation they think it is. And folks, there's links in the chat box, particularly ahs.ca/food insecurity. You can find a lot of the resources that were talked about. Thank you everyone for joining us today. I think we have a hard stop right now at 9 o'clock. So I think we're going to adjourn. Next week, there will be a presentation by Dr. Reena Patani from the University of Toronto. So hopefully everyone can join that as well. Okay, thank you everyone. Thank you so much to the panelists and to the speakers and to everyone for joining us today. Bye.